Welcome to the presentation of desire disorders in women. Low sexual desire has been acknowledged through the centuries as seen by the myriad of aphrodisiacs utilized throughout time. However, disorders of sexual desire were not formally recognized until 1980 with the introduction of inhibited sexual desire disorder to the DSM-3. This diagnosis was the same for both sexes. Some colloquial terms for sexual desire include libido, sexual drive, and sexual appetite. Though most of us are not clinicians, it is important that we are familiar with clinical terms and definitions of low sexual desire. Throughout the past few decades, nomenclature as well as the understanding of the forces impacting sexual desire has evolved. Being familiar with these terms and definitions will not only aid us in our research, but also help us to know when a person may need more professional help than we can provide. At the same time, by better understanding sexual desire, we are better equipped to minister to ourselves and others who may express concern or even distress over low sexual desire. I give you fair warning. Since I have much to cover in only 15 minutes, you will find more information on the slides than I'll be able to cover in detail. Hopefully, you'll find the slides helpful, as well as the resource list at the end to further your knowledge in this area. Inhibited sexual desire disorder was based on Masters and Johnson's 1966 human sexual response cycle model, including the desire phase identified by Kaplan's 1974 work. An inherent feature of the human sexual response cycle is a universal linear series of phases in sexual response deemed virtually the same for men and women. Theoretically, it begins with a spontaneous desire, increases to arousal, then plateaus and moves on to orgasm, and finishes with resolution. Initially, it was thought that this was the normal cycle for everyone. Pathology was based on deviances from this model. In 1994, the DSM-4 continued to organize psychosexual disorders around the human sexual response cycle model, and desire disorder nomenclature was changed from inhibited sexual desire disorder to hypoactive sexual desire disorder. For both sexes, it was defined as persistently or recurrently deficient or absent sexual fantasies and desire for sexual activity that causes marked distress or interpersonal difficulty. Although Kaplan's 1979 work acknowledged the general concept of sexual desire emerging after sexual arousal, it was Bassan who developed this concept more fully for clinical populations, proposing a circular sexual response cycle model for men and women. Bassan's model depicts multiple factors which can impact a person's desire for sexual activity. Bassan's model normalized receptivity to sexual activity for non-desire-related reasons and posited that once physical signs of arousal emerged, and as long as stimuli continued to be effective and the context in which they were delivered was appropriate for women, then the desire for ongoing sexual stimulation or responsive sexual desire was accessed. In 2013, DSM-5 took into consideration Bassan's model as well as other research demonstrating differences between men and women regarding sexual desire and made separate diagnoses for men and women. For women, the DSM-5 combined low sexual desire and arousal disorders into one diagnosis, sexual interest arousal disorder. The DSM-5 included subjective, behavioral, and physical aspects of desire and arousal. This was a very important change. The intent was to recognize that women do not experience desire and arousal problems in a uniform way, even among themselves. At least 3 of the following criteria must be met to have a diagnosis of FSIAD. I will not go over these in detail right now since we've read them in our textbooks and heard about them in class, but please note that the definition for desire in these is responsive desire. It's also important to know to have a diagnosis, symptoms must be present for a minimum of approximately 6 months. They must cause clinically significant distress in the individual. Complaints are not better explained by a non-sexual mental disorder, severe relationship distress, or other significant stressors. Symptoms must not be exclusively associated with consequences of a medical condition, And when substance or medication use can explain the complaints, the diagnosis, substance or medication-induced sexual dysfunction should be made. With all the research that has been conducted on low desire over the last several decades, most of the researchers whose articles I read lament that, unfortunately, despite heightened attention to the topic of low sexual desire, a concise definition of sexual desire has not yet emerged. Difficulties with sexual desire and arousal continue to be the most frequent complaint seen in sex therapy clinics. It is often combined with other sexual disorders. The majority of women with any sexual difficulty state that their low sexual desire is the main source of their distress. Cross-sectional population-based studies of Western women report 30 to 41% of women have experienced low sexual desire lasting several months over the past year. Between 7 and 10% of women report these problems plus significant associated distress. According to the DSM-5 diagnosis criteria, only those 7 to 10% of women who also have significant associated distress with their low desire would qualify for a sexual dysfunction diagnosis. In clinical practice, the complaint of lack of sexual interest or arousal is seldom presented by a single woman, a woman without a sexual partner. Usually the complaint comes from women in a steady relationship and is related to differences in sexual desire with her and her partner. This may point to relationship issues and, of course, lifetime changes. How has low sexual desire among females historically been treated? From the field of psychology, traditional sex therapy based on Masters and Johnson's 1970 program has been used with some success. This form of treatment includes sex education, non-genital and genital pleasuring, communication training, and a variety of interventions designed to reduce performance anxiety. Typically, both members of a couple are involved in treatment. Various medications have been attempted without much success. Viagra for women was found ineffective, and both of these medications never were even approved. The views of society, culture, and religion, familial and marital systems have had and do largely impact and influence our views and attitudes towards low sexual desire in females. For example, media promoted the idea that there was a serious public health concern and unmet medical treatment for female sexual dysfunction following the 1998 approval of Viagra for men. Other ways in which the media has presented low sexual desire in the past decade include: desire is strong and spontaneous rather than reactive and responsive. Good and healthy sex requires frequent and novel sexual experiences. Life events like illness, childbirth, they should not intrude into the regular schedule of having sex. Male desire and orgasm are uncomplicated and ever present. Women's are complex, elusive, and difficult or time-consuming to achieve. Hypoactive sexual desire disorder is common, underdiagnosed, and can have a profound effect on quality of life. Women may not be aware that they are sick or distressed. Simple questionnaires can assist clinicians in diagnosing the disorder. It is problematic that there are medications available to treat sexual problems for men but not women. In fact, there is no scientifically established norm for sexual activity, feelings, or desire, and there is no evidence that hypoactive sexual desire disorder is a medical condition. Pharmaceuticals have gathered support from congresswomen and women's health organizations to promote medications for women. During a public meeting on female sexual dysfunction held at the FDA in October of 2014, the impact of familial and marital system views can be heard in the women's testimonies. Women talked of wanting to be the woman my husband married not too long ago, and feeling guilty their desire for their partner was no longer the same as it was when their relationship began. Cultural and societal impact can also be heard. Women spoke of wanting the closeness, the feeling of well-being that comes with the passionate, satisfying sexual relationship, and to want it all the time. Women spoke of feeling less of a woman and of duty sex. There is a sense that the women felt that desire should remain unaffected by anything outside the bedroom, from the stresses of everyday life to the trauma of cancer. They spoke of normal, but based on what? Cultural cues or based on their normal when the relationship was new? There are multiple legitimate reasons women may not desire sex, but women who do not desire sex are portrayed as having a clinical problem requiring a medical solution. Historically, religion has made the discussion of sex and sexuality taboo. Current treatment protocols in the medical field, we recognize that physiological causes exist. Several medications actually can lower sexual desire, as listed here. Under medical guidance, these medications may be adjusted or replaced with other medications to lessen and the impact on sexual desire. Treatment and management of chronic illnesses is also important as they can impact sexual desire. In August 2015, flibanserin became the first non-hormonal medication to be approved by the FDA for the treatment of premenopausal hypoactive sexual desire disorder. There are concerns over the interactions of this medicine with alcohol, prescriber restrictions, and modest efficacy data. As well, clinically significant risk of dizziness, somnolence, nausea, and fatigue are associated with this medication. A black box warning, the most serious FDA safety alert, is given to flibanserin. Blomers et al. Found that women with low desire may have a blended sensitivity to sexual stimuli. Libido and libidos are designed to address the potency of sexual stimuli and the importance of the brain's processing of those stimuli. It may be that these two medications, which are currently the subject of phase 3 clinical trials, possesses the most promise for addressing the etiology of women's impaired sexual responding. Testosterone is currently widely prescribed without regulation for postmenopausal women with low desire. It should not be used long, and it's not recommended for pre- or perimenopausal women. Other hormonal agents have also been the focus of study, but none have yet been approved by the FDA. A final thought on meds by Chivers and Brodo. We believe that a single pharmaceutical agent that addresses the multiple underlying contributors to low sexual response does not exist. Furthermore, we reject any treatment approach that fails to be sensitive to the contextual, psychological, relational, and larger socio-cultural forces that shape sexual function and inhibit sexual response. When a woman has predominantly unrewarding sexual experiences, there will be very few stimuli that can elicit feelings of sexual arousal. Current treatment protocols in the psychological field. There are several of these. Traditional sex therapy, which includes sex education, non-genital and genital pleasuring, communication training, and a variety of interventions designed to reduce performance anxiety. Reframing desire as responsive and exploring personal triggers of sexual response can be helpful. Addressing anxieties and anger has been found helpful. Anxieties such as guilt over pleasure, sexual pleasure, the fear of intimacy, and unconscious fears of anger. The importance of relationship factors such as communication and power struggles or difficulties has an impact on desire. Importance of having both sexual and relationship goals has been seen in promoting healthy sexual desire. Environmental factors such as atmosphere, activities before and after sexual intimacy, and cognitive aspirations or wishes for sex impact sexual desire. Work on sexual scripts, becoming more aware of and managing everyday life stressors, marital therapy, and relaxation training has all been found to help with sexual desire. Having a partner present during therapy is a significant predictor of better outcomes in this area. And orgasm consistency training has also helped sexual desire. CBT, MBCT, bibliotherapy, emotional intimacy training, and sexual education are all helpful in improving sexual desire. Some final thoughts. Though most of us are not clinicians, we do desire to grow personally and to help others. Though the prevalence of female low sexual desire complaints is high, relatively few may actually qualify as being clinically diagnosed. We have several modalities we can use, from sex education and righting the myths to many other of the interventions listed above, such as bibliotherapy. May we all feel more confident to skillfully and compassionately help and minister to others.